So in chapter 19, we're going to talk about disorders of cardiac function. So with coronary artery disease, we talked about how there's atherosclerotic plaques that can build up in your body's blood vessels. In the last chapter, we said how LDLs can deposit within your blood vessels, causing oxidation by macrophages, which can form these plaques that can plug vessels. Now, when that occurs in the periphery, we call that peripheral artery disease, or PAD. When it occurs in coronary vessels, like the vessels that supply blood to the heart itself, we call it coronary artery disease. And so when these coronary arteries are blocked, it can lead to ischemia, right, which is a lack of blood flow to a particular heart region, which can cause things like angina. Angina is intermittent heart pain from hypoxia. And essentially this is heart pain that can feel like a minor heart attack, but it doesn't cause any long-term damage. And then heart attack itself, which is ischemia that can actually cause damage to the heart muscle itself, can lead to cardiac arrhythmias, like if you get abnormal blood flow to some of the pacemakers of your heart, or conduction deficits, like if you get abnormal blood flow to like the bundle branches. It can also lead to heart failure, and this is defined as your heart's inability to pump enough cardiac output to meet it with your body's metabolic needs. And can also lead to sudden death, like if the heart just totally stops and your cardiac output and your blood pressure just drop out. So this is identifiable clinically through ECG and serum cardiac markers. So on an ECG or EKG, remember this is going to measure the electromagnetic fields of your body due to changes of heart muscle activities. And some of the markers of acute coronary syndrome could be things like an inverted T wave. So instead of the T wave deflecting in upward direction, it might deflect downward. You can see elevated ST segments or depressions, and sometimes an abnormal Q wave that's present as well. And these are all ECG markers of acute coronary syndrome. Now, these aren't definitive. So like just because someone has an inverted T wave doesn't mean that they recently had an ischemic attack. Same with an elevated ST segment. However, we can verify this as well with serum cardiac markers. So there are markers of cardiac muscle injury that can occur in the blood after heart attack. And so some of the proteins that can be released from necrotic heart cells could be things like myoglobin, creatine kinase, and troponin. All of these are markers of heart attack you actually can find in the bloodstream, because these are proteins you normally find inside of heart muscle cells. And if you're finding them in blood, then that suggests then that these heart muscle cells have died. So if we look at a cross-section of the heart, you can see this little local area of myocardial infarct, or basically dead heart muscle. And you can see it's kind of yellow here from the necrosis, and this is going to be consistent with the fact that there's less blood flow and death of these cells. Now, if this were survivable, which this one probably wasn't because it's encompassing a pretty large part of the left ventricle, which you need to pump to the systemic circuit. But if it were survivable, it's possible to live if the necrosis is small enough to not affect the function of the heart significantly. But the problem, though, is that this necrotic tissue is also going to weaken, which can also put you at higher risk for your heart to rupture. Like it could tear at the point of necrosis when it fills with blood. So some of the other sort of signs and symptoms of acute myocardial infarction could be things like chest pain. You might get like a severe crushing or constrictive or heartburn. Now you can tell the difference between heartburn and heart attack, because heartburn, which is actually going to be like esophageal pain, that should get worse upon swallowing. If it's actually coming from the heart, swallowing is not going to change anything with the heart. So you can kind of differentiate between heartburn and heart attack in that regard. But the sympathetic nervous system responds, due to a decrease in cardiac output. It responds by increasing sympathetic output. So you get things like nausea, vomiting, GI distress. It can also lead to tachycardia and vasoconstriction. Also these feelings of anxiety, restlessness, and impending doom. It's almost like people have a psychological feedback from their organ failure. And it can also lead to hypotension and shock. Remember we said that the heart, you need to generate enough cardiac output to basically, generate blood pressure. But if your heart's failing and you can't generate enough cardiac output, it's going to lead to low blood pressure. And if your blood pressure is too low, that can lead to shock, which can begin by weakness in the arms and legs, like the distal extremities. And so people can feel cold in the distal extremities and warmer in the central region, like their trunk. So some of the complications of acute myocardial infarction would be things like heart failure, right? And that's going to be your inability to meet your body's metabolic needs. Cardiogenic shock, where your heart can't generate enough blood pressure to allow for proper perfusion of your body's tissues. Can also lead to things like pericarditis, which is inflammation of the pericardium. Can cause thromboemboli, and so these thrombi and emboli can block heart chambers or distal vessels. May lead to rupture of the heart via necrosis and weakening of the heart muscle wall, so the heart muscle wall can tear, or ventricular aneurysms, where the ventricular muscle can balloon outward from the area of necrosis because of the weakening of that particular wall. So this differs from chronic ischemic heart disease. So acute myocardial infarct would be like you have a blood clot that's an embolus, and that blocks a coronary vessel really rapidly, right? That's acute. Chronic ischemic heart disease is an imbalance of blood supply with the heart's oxygen demands, but in a chronic way. So we're saying this is more than 3 months. And this can either come from either less blood or higher oxygen demand. So one of the forms of chronic ischemic heart disease could come from the fact that atherosclerosis can limit blood flow to an area of heart muscle, or vasospasms of the coronary vessels can also limit blood flow to an area of heart muscle. It may also come from the fact that your heart muscle has higher oxygen demands due to increased activity, and that could be induced by things like stress, exercise, or even cold, and that in itself chronically could actually start to damage the heart muscle tissue. So one of the forms of chronic ischemia is angina. Now, angina is intermittent ischemia without any long-term damage to the heart muscle itself. And so this is an important distinction because angina, although it's painful, doesn't cause heart muscle damage because it's just intermittent ischemia. And so there's different types of angina. Like there's chronic stable angina, where it's pain when the heart's oxygen demand increases. So this would be like you go to exercise and that's when you get the angina or heart pain. There's also silent myocardial ischemia, where the myocardial tissue, like the heart muscle tissue, can become ischemic, but it doesn't cause any pain. And this would be a more identified, like in a echocardiogram, or basically looking at blood flow through the coronary vessels. Or there's also variant or vasospastic angina. This is pain when the coronary artery spasm, and this can be caused by things like allergies or other precipitating factors. And so it's just different subtypes of angina. But across the board, angina does not cause any long-term damage. However, angina, it's some ischemia, but that can lead to, eventually can lead to more dramatic signs and symptoms that can lead to long-term damage. So, somebody might start out with angina that then leads into, things like acute myocardial infarction. So in terms of heart pain from the angina, we call it angina pectoris. There's going to be sort of a burning, crushing pain, sort of a lot of weight here, right around the location of the heart, but that can radiate out away from the heart towards areas like the neck, upper back, even the rest of your chest, the posterior back, or even down the arms. Sometimes it's the right arm, but most often it's the left arm. You get sort of referred pain of the heart in these regions. This is why a lot of times people can think that their angina could be things like heartburn, because it can feel very similarly in terms of locations of that pain. Now, it's important to note all the variants of angina, because not everyone's angina will feel the same way. Like some people might have angina and it only feels like neck pain, or they might have angina and it only feels like just pain right around the chest here. So it just varies from person to person, but it's important to consider the different sites of referred pain. Now, true or false here, chronic ischemic heart disease is more likely to result in stable angina than acute coronary syndrome. Is that true or false? That's true, right? Because we said that ischemic heart disease is characterized by stable angina, and that's associated with plaques that are more fixed obstructions. Now, unstable angina is characterized by plaques with platelets that are stuck to them, and these are more likely to form a thrombus, which can lead to acute coronary syndrome. It's just really just the definition of how the plaques result and what that's going to lead to. Now, we're going to move on to talk about the valve defects, and just some terminology here before we jump into this. Stenosis is a narrowing of the valve. This is where the valve can't open all the way. So you might get like aortic stenosis, where the aortic valve maybe doesn't open fully. And now the problem with the stenosis here is if the valve doesn't open fully, it's going to basically lead to a decrease in blood flow, downstream of that valve. So with aortic stenosis, you might find then that people have a decrease in cardiac output because they can't get all the blood out of their left ventricle. But it's also going to lead to a backup of blood upstream from the valve. So for instance, if someone has aortic stenosis, blood can back up into the left ventricle and cause like ballooning of the left ventricle because the left ventricle's got to stretch to accommodate that extra blood that's not being forced along. Now that differs from regurgitation because regurgitation is where the valve doesn't close all the way. So with regurgitation, we're seeing that the valve, by not closing all the way, this can lead to backflow. So for instance, with mitral valve regurgitation, and this is where basically the left AV valve doesn't close all the way, when the left ventricle contracts, that blood then can flow back into the left atrium and cause a ballooning of the left atrium and put a lot of stress on that part of your heart. And so it leaks when it's closed because it can't close all the way. And so, with, just in terms of characterizing valvular disease, we'll talk about the aorta here. But when the valve leaflets can thicken, become stenotic, right, where they don't open all the way, where this might be a condition where you want the aortic valve to be open because the left ventricle is contracting. If it can't open all the way and you're forcing blood through a smaller space, that's going to put a lot of stress on your heart and also going to decrease cardiac output. We also might find, too, that if valve leaflets are damaged and they're retracted and fibrosed, this can also cause regurgitation where essentially they're not closing all the way, which can also lead to backflow. Now, if it's the aortic valve, then we're saying then that blood can back up into the heart instead of being forced along, and that can lead to problems of cardiac output and blood pressure. Now, these AV valves are the ones that separate the atria and ventricles, and if the AV valves going to the ventricles don't work, then we say that these are mitral or tricuspid problems. Now, because this is just another name for these AV valves. And this is going to either put a lot of stress on your ventricles or your atria. And if the semilunar valves don't work, we're saying that these are aortic or pulmonary problems because these are the names of the valves that go to those respective vessels. Like we have the aortic semilunar valve and the pulmonary semilunar valve. Now, for different types of valvular disorders, remember we talked about there's the mitral valve and the aortic valve. Now for the left side of the heart, the mitral valve separates the left atrium from the left ventricle, and you can have stenosis, regurgitation, or prolapse. Now if it's mitral valve stenosis, what's going to happen here is that blood's going to back up into the pulmonary circulation, and it's going to lead to a lot of blood buildup in the left atrium, because that blood then can't be forced very well in the left ventricle. That's going to lead to a decrease in cardiac output and a decrease in blood pressure. Now with mitral valve regurgitation, this is going to lead to a backflow of blood from the left ventricle back into the left atrium, and that's also going to lead to stress on your pulmonary circuit, but also cause a decrease in cardiac output because of inefficient stroke volume. And then with prolapse, we're saying here that the valve leaflets basically just forced back all the way, and they're almost not functioning at all. And this mitral valve prolapse can lead to massive backflow of blood. Now, with aortic disorders, remember the aortic valve separates the aorta from the left ventricle. So if someone has aortic valve stenosis, then we're going to see that blood can't be forced out of the left ventricle very well. And so you're going to see a decrease in cardiac output and a lot of stress on your left ventricle. So the left ventricle is going to have to work harder to pump blood out through this narrow valve. And if someone has aortic valve regurgitation, they're also going to have a decrease in cardiac output because blood's going to flow back into the left ventricle rather than continuing forward and throughout your blood vessels. So true or false here, mitral valve regurgitation results in diminished stroke volume. We said that that's true, right? Because if the mitral valve can't close fully, then blood's going to flow back into the left atrium, which is going to decrease stroke volume, which is going to decrease cardiac output. So this next discussion here is defects in which valves might cause these particular symptoms. So let's say if someone has severe dependent edema, let's say that there's severe edema in the peripheral extremities. Well, that would be, a right-sided heart problem because the right side of the heart receives blood from the rest of their body. And so if blood's backing up into the vessels of the body, that's going to lead to edema. And so that would be more of an issue of, let's say, the right AV valve or the tricuspid valve, like regurgitation of the tricuspid valve. Now, Paroxysmal nocturnal dyspnea, as we're saying that it's basically difficulty breathing or shortness of breath while sleeping. And so shortness of breath can either be due to a dysfunction of the right side or the left side of the heart. Remember, the right side of the heart pumps blood to the lungs, left side of the heart receives blood from the lungs. So if someone has, let's say, aortic stenosis, and blood's backing up into the lungs, that can also lead to shortness of breath because they're not really forcing blood along and oxygenating their tissues. But that blood backing up the lungs can also lead to pulmonary edema, which is going to cause sort of fluid to build up in the lung tissue, which makes it more difficult to ventilate. And you might wonder too, like, what valvular problem could cause a congested liver? Well, we talked about how the liver is part of your systemic circulation, and that's going to dump blood into the inferior vena cava, which then drains into the right atrium. So if there's a problem with the right AV valve, like let's say if the AV valve is stenotic and there's too much blood backing up into the systemic circulation, that's going to also cause congestion of liver circulation. Same with distended jugular veins. Or if someone has a productive cough with frothy sputum, like what's going to cause this particular symptom? So that's going to be, basically pulmonary edema where blood's building up in the lung. Fluids building up in the lungs due to high blood pressure. And this can either come from right-sided or left-sided problems. We would see this probably in terms of valvular dysfunction, probably more with the left side, because if blood's backing up into the pulmonary veins, that's going to increase pulmonary pressure, which can lead to pulmonary edema, causing productive cough with frothy sputum, as well as rales, which is like a crackling within the lungs itself. So we talked about the cardiac cycle earlier. And we said that the cardiac cycle is essentially all the events that occur within a single heartbeat. And just to kind of summarize this process, we talked about how, as a cycle, you just got to pick a starting point, right? So let's start with the AV valves open, right? And so while the AV valves are opening, the ventricles are filling. And while the ventricles are filling, they're currently relaxed. And so after ventricular relaxation, then you get ventricular systole. And when the ventricles start to contract, the AV valves close, which cause your first heart sound. That's S1, which is the lub sound. Then what happens is that your semilunar valves open, and then blood's ejected out of the heart. And then you end up going into ventricular diastole or relaxation, which then causes your semilunar valves to close, causing the second heart sound, which is dub. And then what happens is that essentially your AV valves open up again, and your ventricles start to fill with blood while they're relaxed. So we went full circle here, and that's just essentially the events that occur within a typical cardiac cycle. So what's cool then is that we can identify problems with the cardiac cycle by listening to heart sounds. And so we know that S1 is caused by closure of the AV valves, and S2 is caused by closure of the semilunar valves. And so heart murmurs are just sort of abnormal sounds of the heart. And so we talk about heart murmurs as occurring either with S1 or S2, and that can indicate problems with these valves. So we know that if there's an S1 problem, that's going to be an AV valve dysfunction, whether it's stenosis, regurgitation, or prolapse. And if it's S2, that's a semilunar valve problem, again, whether it's stenosis, regurgitation, or prolapse. And so if these heart sounds are supposed to be like lub-dub, 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 they might be something more like lub-bub, dub, lub-bub, dub, where the valve kind of murmurs, right, kind of trails off. This could be from like dysfunctional leaflets or just odd blood flow, which can lead to different sounds. So pericarditis is essentially inflammation around the heart, or pericardium, and this can lead to pain. It can be caused by exudate, and the exudate can either be serous or sanguineous, right, like serous fluid or blood. It can also be chylous, which is fatty lymph. But with all of these exudates and the effusions that can lead to, what we find is that if that fluid accumulates between the heart and the pericardial sac, this leads to rapid accumulation of fluid that can compress the heart and prevent adequate heart filling. And we call that cardiac tamponade, which essentially there's so much external compression on the heart because of fluid buildup that the heart can't adequately fill with blood. Now, if it's a fibrous exudate, this can actually lead to fibrinogen that can lead to adhesions that cause friction rubs, and this can also be painful. Now, sometimes you can actually identify pericarditis, and the associated electrical changes can show up on ECGs. So inflammation of the pericardium can restrict the heart's movement. That can either be due to serous or fibrous exudates. Now, if it's a serous exudate, this can lead to pericardial effusion, which also limits adequate filling of the heart. which we would call a cardiac tamponade. And if it's a fibrous exudate, this can actually lead to adhesions that limit your heart's ability to move, and that can also be painful and also limit adequate filling of the heart. We call that constrictive pericarditis. So in terms of the consequences of effusions, in terms of fluid filling the pericardial cavity, it can restrict heart expansion. The left ventricle can't accept as much blood, which leads to a decrease in cardiac output, a decrease in blood pressure, and it might be so much that someone actually goes into cardiogenic shock, where their blood pressure is so low they can't supply their body's tissues. So if the right ventricle can't accept enough blood, you get an increase in venous pressure, and you get jugular venous distension. And you might wonder, why would you look at the jugular veins? Well, the jugular veins are pretty superficial in the neck, and because they're superficial and easy to access, they're something that's really easy to look at. There are also other superficial veins in the body, but typically people's necks are exposed, so it's easier to identify, venous distension via the jugular veins. So there's another interesting condition called Pulsus Paradoxus. And it's a fascinating condition where on inhaling, the right ventricle fills with extra blood, and because the heart can't expand fully when the right ventricle is overfilled, the left ventricle is actually compressed and then can't accept as much blood, so that on the next heartbeat, the left ventricle can't send out as much blood, which actually decreases cardiac output and decreases blood pressure. So it's this really odd condition where, because of the fact that you take a deep breath during ventricular filling, if the right ventricle fills with too much venous blood, it actually compresses on the left and leads to a decrease in cardiac output. So it's kind of a fascinating condition. And this would be treated by essentially training people to take adequate breaths. If the breaths are too deep and just timed right, they can have too much filling of the heart, which can limit cardiac output. So this next question here is, what's the most immediate treatment for severe cardiac tamponade? Remember, cardiac tamponade was an accumulation of fluid around the heart. So would it be oxygen, cardiac drugs, surgery, or pericardiocentesis? Well, pericardiocentesis is the removal of fluid from the sac via needle, and by draining the fluid, then you're immediately repairing the problem. That way you get less pressure on the heart, so the heart can actually fill adequately. And remember, these pericardial effusions can be made of blood, they can be fatty lymph, which is chylous, or they can either be serous fluid as well. So other cardiomyopathies can be primary or secondary. If it's a primary cardiomyopathy, we're saying that it's genetic, or it could be mixed or acquired. Genetic cardiomyopathies can be like, hypertrophic growth of the heart muscle, or arrhythmias. If it's mixed, we can say that basically the heart muscle can either be dilated or restrictive. And so dilations of the heart muscle can limit their ability to basically contract properly. And if it's restrictive cardiomyopathy, we're saying that the heart muscle can't stretch adequately, so it can't fill properly. And if it's acquired, we're saying here that it could be things like viral myocarditis, like certain viruses like to attack heart muscle, or it could be things like Takotsubo cardiomyopathy as well. Now, secondary cardiomyopathies come as a secondary consequence of other problems. So, for instance, somebody might have pulmonary dysfunction, let's say like COPD, like chronic obstructive pulmonary disease, and that due to damage of blood vessels, that can actually cause a lot of resistance through the lungs, which puts extra stress on your heart, and that can also lead to cardiomyopathies as a secondary consequence of other organ damage. Now, hypertrophic cardiomyopathy comes about from defects in contractile proteins, and it makes these cells too weak. So what's interesting then is that the cells have to become hypertrophic to perform the same amount of work as normal cells. But the problem here is that these cells need more oxygen, and when the cells increase in size, it limits the size of the ventricles, so the ventricles can't adequately fill with blood, and that in itself can lead to heart failure, especially during exertion. So if we compare the difference between a normal heart and a hypertrophic heart, you can see with a normal heart, the right ventricle is fairly thin and the left ventricle is approximately 3 times thicker. With a hypertrophic heart, you can see that the muscle gets significantly thicker here, and that the ventricular septum could get so thick that it starts to block the aorta, and that because of narrowing of the left ventricular volume, it can't fill up with as much blood, which means you limit cardiac output, so the heart has to work even harder just to get the same amount of blood out of the heart. And that is actually positive feedback, because then your heart muscle gets stronger and bigger, which also makes this heart chamber smaller. Now this question here says, which type of cardiomyopathy is characterized by weakened ventricles? Is it dilated, hypertrophic, restrictive, or peripartum? We know it's dilated, right? So dilated cardiomyopathy is when the ventricles are too weak to pump blood, which leads to diminished cardiac output. So other types listed cause actually thickening of the ventricles or stiffening of the ventricles, so that it's not necessarily weakening, but rather just like they're getting too large or getting too stiff. So we actually can use shunts to get around blockages within coronary vessels. So one of the disorders that's pretty common is coronary artery disease. And if these atherosclerotic plaques get too large, shunts can be applied to get around that blockage. That way you can reestablish adequate blood flow around the heart. This is what we would call a bypass surgery. So it's an opening or connection that lets blood move from one side to the other. Now, we can also have circulatory shunts, which you find in a fetus, and these circulatory shunts can help to divert blood flow from the right side to the left side of the heart. And the reason for this is that, as a fetus, you're not using your pulmonary circulation. Fetuses don't breathe under, in the amniotic fluid. So what happens is that fetuses actually get their oxygenated blood from the placenta. It comes back through the body via the umbilical veins, and it spills right into the inferior vena cava. So these shunts then help to divert blood flow away from the pulmonary circulation straight into systemic, which is the left side. So most occur in the heart and move blood from the the right to the left side of the heart. Well, because the left side is stronger, blood's usually pushed from the left to the right side as well. So there's a little bit of backflow. However, you want to actually, move blood into the systemic circulation. So some of the shunts that are normal before birth would be like ductus venosus, foramen ovale, or ductus arteriosus. Ductus venosus lets blood flow from the visceral veins to the vena cava, which helps bypass the liver. So like the umbilical veins can go straight to the inferior vena cava through ductus venosus. That way the liver doesn't use too much of that blood. And then foramen ovale lets blood flow from the right atrium to the left atrium. And then ductus arteriosus actually helps blood to flow from the pulmonary trunk straight into the aorta. Therefore, you can bypass the lungs. So both of these, like foramen ovale and ductus arteriosus, help us to bypass the lungs. Ductus venosus helps blood to bypass the liver. That way the liver doesn't use up all your oxygen. So these left to right shunts, less blood to the body, but there's more blood to the lungs. And so, this would be not desired, especially after birth, because then you're going to see that blood's being forced back into the pulmonary circulation. And these right to left shunts are more desired before birth. That way, deoxygenated blood goes to the body. Deoxygenated blood from the body actually goes back to the placenta, and you can also send less blood to the lungs. So this discussion here says, which way would blood flow in a patent ductus arteriosus? So remember, ductus arteriosus helps to connect the pulmonary trunk to the aorta, right? Now, with a patent ductus arteriosus, because your systemic blood pressure is higher than your pulmonary pressure, some of the blood from your aorta is going to flow back through this ductus arteriosus back into the right ventricle. So you're actually going to lose some of that oxygenated blood back into the pulmonary circulation. And then with the transposition of the great vessels, this is actually a flip-flopping of the aorta and pulmonary trunk. So what's weird with the transposition here is that we find then that with the right ventricle, that might connect straight with the aorta, and the left ventricle could connect straight with the pulmonary trunk. Now that's a problem, because now what you have then are two disconnected circulations. Because if the right ventricle is receiving blood from the body but pumping that blood to the rest of the body, that means that that deoxygenated blood is never getting to the lungs. If the left ventricle is receiving blood from your lungs but only pumping blood to the lungs via the pulmonary trunk, then again, that oxygenated blood is not getting out to your body. Now, transposition then is actually going to be not compatible with life. This has to be repaired like right at birth or even in utero. And then the tetralogy of Fallot is actually a congenital disorder where you find, large we call them, patent ventricles. And so blood can flow between the left and right ventricles pretty readily, as well as blood can flow through the right and left atria pretty readily. And so tetralogy of Fallot leads to excessive mixing of pulmonary and systemic blood, which can lead to pretty extreme cyanosis in newborns. And again, this one has to be repaired surgically. So with the different congenital heart defects, we'll have all of these listed here. So remember, with a patent ductus arteriosus, we're saying that the pulmonary trunk and aorta remain connected after birth. And with an atrial septal defect, we're saying here that there's a patent foramen ovale, and so that the left and right atria are still connected, and so there's a mixing of blood there. With a ventricular septal defect, the ventricles are connected, and again, there's a mixing of blood between the pulmonary and systemic circulates. With the endocardial cushion defects, this endocardial cushion cells are the ones that help to guide the development of 4 chambers. If this fails, then the heart might not adequately develop all the 4 different chambers that it should have. With pulmonary stenosis, you could have narrowing of the pulmonary trunk, which puts excessive stress on your right ventricle. Tetralogy of Fallot is basically a ventricular septal defect and a patent foramen ovale together. Transposition of the great vessels is basically where you have the right ventricle connecting with the aorta and the left ventricle connecting with the pulmonary trunk, which again leads to 2 non-communicating circulations through the body. We have coarctation of the aorta, which is a narrowing of the aorta, puts a lot of stress on your left ventricle. And then we have this functional single ventricle anatomy where you don't develop a ventricular septum, and so the ventricle is just one large ventricle that connects with the pulmonary trunk and aorta. And this leads to a lot of mixing of pulmonary and systemic blood, again, which leads to pretty excessive cyanosis.